Hello, my name is Cynthia Roberts. I'm from The Ohio State University, and I'm here today with my colleagues to talk about the importance of biomechanical assessment in a clinical practice for the general ophthalmologist. A new device has been introduced recently called the Corvis ST. It's a very exciting device in that it combines an air puff tonometer with a high-speed Scheimpflug camera, and that camera acquires a video of the cornea deforming in real time and allows us to analyze the video to assess corneal biomechanical response. And it's been in use for a number of years by the world's leading ophthalmologist, who I happen to have here with me today. And so I would like to ask each of you gentlemen how you use the Corvis in your clinical practice and how you rely upon it to take care of your patients. David, would you like to start out?
Well, for me, it's screening for refractive surgery, first of all, screening for ectasia detection, measurement of biomechanically corrected IOP, and evaluation of corneal stiffness before and after laser vision correction and after cross-linking for keratoconus.
Riccardo, how do you use the Corvis in your practice?
Well, as you said, Cynthia, I think that this instrument got more exciting in the last years because we went from having an instrument that was only research and now is fully inside clinical practice. So I believe that now the main applications of this instrument, particularly for a cornea specialist, is the screening for ectasia, early ectasia, but also for subclinical keratoconus, so those patients who do not have a lot of shape changes, maybe only posteriorly on in the epithelial map, but they can show early biomechanical abnormalities that would rule out, for example, a refractive surgery, or would suggest to the clinician to follow them up more for a possible cross-linking.
And do you think you can use that to determine what the final outcome might be from the cross-linking procedure?
Yes, and you're more reassured if you see that the treatment is effective not only with the demarcation line, but you also see a stiffening effect, and you can tell this to the patient rather than just wait and see for months.
Okay, and now we turn to Renato, who has actually had the longest experience with the Corvis of anyone in the world, since you had the very first one. So tell us how the use of the Corvis has evolved in your practice.
Absolutely. It's very interesting that I was very much involved with the research for the subclinical ectasia detection, but I think the most important application of the Corvis is still tonometry. It's a great tonometer, and I can tell you that we have seen patients that have low pressures measured with Goldman and high pressures by the Corvis, and this is a very important application for the clinician. Of course, the ectasia detection, the ectasia prediction, and the control for the ectasia treatments, as we see keratoconus and ectasia as a new subspecialty in ophthalmology, are very important for all of us. But I think for the general ophthalmology, the Corvis is a great tonometer.
Riccardo, you have developed a new biomechanical index, and I wonder if you might tell us how you developed it and then how it's going to be useful to the general ophthalmologist.
Yes, thank you, Cynthia. This was an index that we developed together with Renato. It was a very important multi-center study between Rio de Janeiro and Italy, and the aim of this study was to create an index similar to the Bailey Ambrosio that would be able to easily detect frank ectasia without looking at many indexes and the video of the Corvis, what we were doing before, but just easily separating patient with keratoconus and without. So we divided the dataset in two, and we used one of them to create the index and the other one to validate it and exclude overfitting. And the sensitivity and the specificity of the index was more than 98% in both datasets.
Now that's very impressive for frank keratoconus. What would you do in a case of subclinical or formed thrust keratoconus?
We actually gathered the two datasets with Renato, and we have done another analysis in more than 100 formed fruit keratoconus, or subclinical ectasia, or very asymmetric ectasia, how you want to call it.
Could you define that for us?
Well, it's an eye in which one eye is a frank ectasia, but the other eye has no tomographic and topographic signs of ectasia, so you would either define it subclinical, but we know that probably keratoconus is not unilateral, most of the time is bilateral, so you could also call it very asymmetric because of the susceptibility of the ectasia. So we use the CBI, and in many of these patients, regardless of the fact that the tomography and topography was normal, the CBI was abnormal in both eyes.
And I think, Renato, you also have some experience with this. I wonder if you might share that with us.
Yes, I think it's a very important topic to make the concept what we are trying to detect. When we screen for ectasia risk before refractive surgery, we are not trying to detect keratoconus. And eventually the detection of keratoconus is much easier for us because we have a situation that we have a clinical scenario. The subclinical is a very complex, and people don't agree. We have a consensus, actually have a consensus in Latin America and a global consensus, and we don't agree what is form fruus keratoconus. Actually, fruus means incomplete, means confused, and we don't agree what it is. So there are different concepts for what it is, but we are trying to detect ectasia susceptibility. For example, when I try to establish the population for testing the studies, the very symmetric ectasia cases are the best population we have. And
because it's very objective.
It's objective, and you have to be objective because we have one eye with frank ectasia, and the fellow eye has a normal topography. That's where we define the normal topography with objective indices, and we have to use classic indices like Rabinowitz and Kleist indices for the objective, saying that those cases have normal topography with a P, the front surface.
The anterior surface.
The anterior surface, absolutely. In those cases, we have about 90% of sensitivity with the new TBI, which is an integration using artificial intelligence software that gets multiple parameters from the Pentacam shape data and from the Corvis. And this is something that has been much better from just using the Pentacam, which would be giving us today about 80% of sensitivity. And this increase is not only on sensitivity, it's also going to the specificity. There are cases with borderline topographies that the TBI has helped us to say those cases are more like a warpage or some irregularity.
So the TBI actually takes information from both the Pentacam and the Corvis and combines it using machine learning to come up with a better index for detecting these very early cases and cases that may be at risk for surgery.
Absolutely. Like Dave just said, he has the Pentacam and he has the Corvis data, and the computer integrates the data into one display. And this display gives you objectively the TBI, which is a tomographic and biomechanical index. And that number is very accurate for detection of ectasia.
So David, you use this TBI in your clinical refractive practice. So can you help share with us how it has helped you determine which corneas are at risk? And then perhaps if you detect a cornea that's at risk, what is your decision process on how to proceed?
A good example, I think, would be a patient I saw a couple of months ago. She was a long-time contact lens wearer. She came to the clinic, even epithelial mapping and tomography showed frank ectasia, a clear-cut cone, but normal CBIs. I treated her for ocular surface disease, followed up about 6 weeks later. Clear corneas, no evidence of the cone, disappeared.
The cone disappeared.
Yes. So it was a clear-cut case of lens warpage. And it would be, I think, very interesting when we operate on this patient, on this eye, and follow her up for a long follow-up period to see the longevity of the temporal changes.
Renato, I think it's also important to add, because a lot of colleagues are asking us if the TBI that you developed is only a combination of Belin, Ambrósio, and CBI.
Mm-hmm. It's a very good point, Riccardo. Thank you for reminding us to make it clear that the TBI is a combination of Pentacam data and Corvis data. So when people think about Pentacam data, they would believe that everything is on the bad D, which is a great parameter, by the way, but we have much more complex interactions with artificial intelligence using the random forest. It's a great work by my colleague Bernardo Lopes. He did a combination of multiple artificial intelligence techniques, and the random forest with leave-one-out cross-validation was the best method for us to develop the TBI.
So the CBI was developed and optimized with only biomechanical parameters. And the BAD-D was developed and optimized only with tomographic parameters. But the TBI, rather than taking these indices that were limited in their development, took all of the raw data from both devices and put that into the development of the TBI. So a new index was developed for the TBI.
I think one of the main points is the method for the construction of the parameter. Both the CBI and the BAD-D are constructed using linear regression analysis, which is a very powerful but relatively limited way of combining the data. We use much more sophisticated artificial intelligence techniques, and we tested all those, and the random forest was the best one.
So Riccardo, I wonder if you might tell us how this CBI index you developed is used. Can it be used for screening and progression, or how should the clinician use this index that you developed?
Cynthia, this is a very good point, and I would like to make a summary not only on CBI but also BAD-D and TBI. All these indexes are developed to make a diagnosis. So they're not good to evaluate progression, they're not good to evaluate regression, and they're not good to classificate or evaluate the change in the shape. So because they are created to have a cutoff, and when they get abnormal, the only way to go back would be to have a brand new cornea that is absolutely normal.
And is there a component of the CBI that you might be able to use to track progression or to look at individual response over time?
Yes, absolutely. And these are the single parameters that we have inside the CBI, such for example as your stiffness parameters, inverse concave radius, and we have seen in some studies after cross-linking that they do get significant changes after cross-linking, showing stiffening of the cornea. So those could be very valuable indexes.
So the stiffness parameter that came from Ohio State is actually just the load applied over the displacement. So it's a general term that would allow you then to track progression or regression of an individual cornea.
Yes.
Now, since you brought up cross-linking, I know all of you have experience using the Corvis in cross-linking, and actually, I think I'd actually like to start with you, David, because I think what you found is an ability to detect biomechanical changes from an accelerated cross-linking treatment, which is really a very short treatment, and so it demonstrates really the sensitivity of this method. Could you describe this for us?
It's on a paper we recently published, this group recently published a couple of months ago. We performed trans-PLK, a refractive procedure on one group of patients, and trans-PLK extra with 2.7 joules of accelerated cross-linking at 30 milliwatts for 90 seconds after a 90-second soak. So yes, it was very short. The ribose we used was from a prefabricated solution provided from EYEREUM. And we found at post-op 6 months, less deformation occurred in the accelerated cross-linked corneas than the PLK corneas alone.
So less biomechanical change?
Yes. However, the biomechanically corrected IOP was constant before and after surgery in both groups.
So it's very important to understand when we look at this that the biomechanically corrected IOP did not change, and yet the biomechanical response did change. And you were able to detect a difference between the group that received the accelerated cross-linking and the group that did not. And I think this is probably the first time that someone has actually detected a true biomechanical difference with accelerated cross-linking.
Yes, we are quite excited about this.
Now, Riccardo, you have experience using the classic Dresden protocol in treating keratoconic eyes with corneal cross-linking. Can you describe that experience to us?
Yes, sure. We recently have done a study and we evaluated the effect of the modified, actually, Dresden protocol because it was with 6 milliwatts, but still 5.4 joule. And we wanted to evaluate if we are able to prove any stiffening effect at the early months when we don't have any shape changes, and we were able to show significant stiffening in almost all the corneas just 1 month after cross-linking.
So that's pretty exciting,
Yes,
because the 1 month time point if you just look at tomography or topography after cross-linking is when it can actually get worse, when the epithelium is regrowing. So at the time when the shape is at a non-optimal condition, you actually found significant biomechanical changes with the Corvis.
Absolutely.
So that's pretty exciting as well. Renato, could you tell us about your experience?
Yeah, we first look at the videos, and I remember the compelling of the composing data pre and post that you've done with Ashi were very, very nice for us to see the deformation that was less after surgery, and even though the cornea was getting thinner after Athens protocol. So this is very important for us as a clinician, that we are thinning a cornea that is already thin, but the cornea is more stable. And I think, like the point that Riccardo just mentioned, is very important for the patient as well, because sometimes the patient gets worse vision, and he can feel that. It's obvious for them.
At 1 month.
At this early time points. And we have to give them, this is in the right direction. And all the studies have shown that between 1 to 3 months they get much better. And this is very important to give us one objective index.
Now, I just want to clarify the patients that you discussed where you do ablation and then the keratoconic patients where you do an ablation and then cross-linking. This is a topo-guided ablation, so it's not a standard ablation.
Yeah, you have to be topo-guided, and you have definitely not to think about refraction as a sphere. We have to think about the irregular astigmatism treatment, and you need to do it topo-guided, and eventually in the future we will be doing true tomo-guided.
And that focuses the ablation away from the cone.
Absolutely. You
have and causes a biomechanical change. So I think the important message that you're giving us from a clinical perspective is, despite what's in the literature, the Corvis is actually able to detect real biomechanical differences after cross-linking. Yes. And you've all experienced that.
And soon the literature will be showing you that too.
Okay. Yes, soon these papers are going to, actually both of them are now in press, isn't that correct? Yes. So pretty soon the literature will actually reflect that the Corvis is able to detect true biomechanical changes with corneal collagen cross-linking. Okay, in closing, gentlemen, we've talked about our current usage of the Corvis in clinical practice, but I'd like you to look into your crystal balls, and I'd like you to think where we're going to go in the future, as Renato has just pointed us in that direction. And David, I'd like to start with you. What do you see as the future uses of the Corvis in your practice?
I think the primary endpoint for most general ophthalmologists and refractive surgeons is evaluation of post-op corneas, discriminating between stable and those at risk for future ectasia. We need to develop post-op indices, and this is a direction that I think we really need to take.
All right. Riccardo, what do you see as the future for the Corvis?
So beside what we talked about, I think that there are two big fields in which we can work on, and something is modeling of surgery, so having an index of biomechanics that will help us to model the surgery, either cross-linking or refractive surgery. And another big field in which corneal biomechanics will help a lot, I think, will be glaucoma, because we have seen in early studies that some kind of patients with glaucoma, they tend to have alterated biomechanics that might be one of the causes or just a confounding factor, but we will have to study this more. And particularly normal tension glaucoma, they have this kind of alterated biomechanics.
Okay. And Renato, I'd like to go back to something that you mentioned yesterday in a conversation, that some patients with keratoconus, because they have high IOP, demonstrate stiffer behavior and are harder to detect. So I'd like to ask you to look into your crystal ball about how you might use IOP more effectively in the future to even improve further than what you have so far.
I just recall a patient that came as a second opinion after LASIK with ectasia in one eye, clear ectasia. He lost his vision in one eye, and the other eye was seeing relatively well. And you see the tomographic changes of early ectasia. The posterior float was very high. Even you see some inferior stiffening, but he was still with good vision in that eye. But that patient had pigment dispersion, clearly, with Gruckenberg spindle. And his pressure were like 45 with the Corvis measurements. And I called the doctor, and he said his pressure has been always around 12 with Goldman. So I believe this patient will be at very high risk for losing vision if we don't have the IOP measurements. And this was a poster that was awarded at ASCRS. So I think that the future of the Corvis is going to be not only for refractive surgery, and I agree with both of them, for screening and even for planning. And the surgery is going to be getting safer and more efficient. More efficient because we have modeling for planning better surgery with the algorithms on biomechanical setting for the surgery to be even better.
Okay, thank you very much.
Thank you.
Thank you.
Thank you.